Alrighty, I'm going to go ahead and get started. We've got a decent amount of folks on. People will join as we go. Let me share my screen here. So today's topic is on more of a specific progressive neurologic disorder that fits into this group of primary progressive aphasias, but primarily we're talking about language today, although I'll differentiate that slightly with speech production too. So one of the objectives, I do want to at least define what we're talking about as far as primary progressive aphasias, but I will tell you this can be a very complicated topic. I think it really took me through fellowship seeing these cases for it to really solidify. But with that in mind, I'll show you guys a couple of videos today. So we might go a little bit long just so I can do that. I would say don't get bogged down in the details and remember to refer to your speech pathology, speech therapy colleagues for a full language evaluation. I will tell you most neurologists are not going to do a full language evaluation. It's a pretty comprehensive exam, and it can take up a majority of the time. So again, I'll show you some case examples here. You should know that there are two main subtypes as far as how we group these disorders. So frontotemporal dementia usually deals with the frontal lobes and the temporal lobes, right? That fits with that description. But there is a semantic variant that particularly affects the anterior temporal lobe, and then a non-fluent variant, which typically affects more of the frontal lobe. And then separate from the frontotemporal subtypes are more of what we call an Alzheimer's disease subtype, which is logopenic aphasia. At the end, we'll at least discuss treatment options. Again, these are extremely limited. Again, going to highlight the role of a speech language pathologist, particularly early on, to try to help with compensating for language difficulties too. So one thing that you do have to kind of have straight in the history is that this is a primary and initial language problem, at least early on. And so this does not include individuals that develop aphasia later on in their dementia syndrome. These language symptoms must come first, although I will tell you that can be very tricky depending on which questions you ask and how you ask them, right? So if somebody is more of a language-focused neurologist, they're going to ask different questions than a general neurologist or a stroke neurologist, right? So our history taking is really key here. But if it's very clear that language preceded memory symptoms or language preceded other cognitive symptoms, then that's where you can be more certain that's what we're dealing with. So part of this is the incidence, is pretty low. So you're not going to see many of these cases, especially in primary care, but even in general neurology. And again, detailed language testing is time consuming. And so I'm just basically reiterating a couple of these things here. The main takeaway is I want you to realize that PPAs do exist, and what does that workup look like, right? So detailed neuropsych testing is recommended because they do a fairly comprehensive language assessment, at least at kind of like while you're getting a broad cognitive assessment, because sometimes these actually are multi-domain dementia syndromes that we don't really realize until we do full neuropsych testing. A brain MRI scan is important. If this patient is having a language disorder that is due to a stroke or a brain tumor, that would be good to know early on rather than later. A speech pathologist referral is recommended, again, for that detailed language testing. And then, if this does indeed look like a primary progressive aphasia, that's where really that cognitive behavioral neurology referral makes more sense, especially if you've ruled out other things that, would be a different neurologist that they should be seeing. When we sort of talk about screening, these cognitive domain screening things, I think a lot of us focus on memory. That's the majority of what we see when somebody's coming in with a cognitive concern, right? But there are ways to ask questions about language, and then a couple ways that you can even just within a couple minutes assess a few key aspects of language just to get a sense of, is that something that might be going on here? So I sort of highlight this domain for what we're talking about today. Now, this sort of like, you could quickly have them name 3 to 5 objects in the room, right? You usually want to give some complexity to some of those objects. You can have them repeat a sentence back. You can have them read a small paragraph or write a sentence, see if there's any grammar errors or spelling errors. Have them follow multi-step commands. Do they have receptive language abilities? Something as simple as touching your right thumb to your left ear, right? So sort of that multi-step command. And then you can have a picture that they narratively describe. And so those are just some simple ways to quickly assess language. But I will highlight too that you can also do a focused speech exam. So speech is slightly different than language in the sense that that is our motor production of word and sounds. And so that in order to produce sounds, you have to plan motor speech and then execute it, right? And so that does not necessarily equal language here. It produces language, but we can assess this pretty quickly with simple things like what we call alternating motion rates, having a patient say pa, 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 ta, 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 ka, 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 ka. You want to see that that is sort of like a similar sound coming out each time. And then you can kind of put that together with more of a sequential motion rate of, can they go pataka, 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 right? Does it sound the same each time? Or are there's these irregular distortions of speech, which would indicate a potential planning issue? I like to use sort of a progressive multiple syllable words, which you'll see this used in some of the video examples I have here. So this next puzzle here. So this is an 80-year-old with 3-year history of cognitive concern. So that's usually, things are pretty vague when they're first coming in. She describes it as difficulties getting my words out. And you note that she's got some slowed speech patterns when she's describing this. Sometimes she'll say yes when she means no. So there's a little bit of this yes-no reversal. She's not really having any difficulties with spelling or reading. There's really no other cognitive or memory complaints here. She's been seen by multiple providers without any sort of clear diagnosis, and actually has been labeled as having a functional speech disorder by one of the neurologists they saw. On exam, so like a short test of mental status, that's the cognitive assessment I would do in our memory clinic. She scores pretty normally, just very, very mild cognitive impairment with no specific pattern, scoring 33 out of 38. Her language exam is normal except for this slow, distorted speech. And so one way we can tease that out is having her repeat these multiple syllables. So she does fine with cat, 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 but then struggles with catapult and catastrophe. And really, the rest of her neurologic exam looks pretty normal. So I'm going to try to do this real quick. This video launches, here we go. Going to move this over here. And then I think the one thing I have to do is share sound. Here we go. Let me know if you can hear this. You should be able to.
Catnip, catnip, catapult, 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 catastrophe, catastrophe, catastrophe.
Can you guys hear that all right? Can somebody confirm?
Yes, yes,
Perfect.
we can hear it. Thank you.
Perfect. So that's like 1.5 years. That's very subtle. That would be really hard to diagnose early on. But listen, this is just 3.5 years in. So the difference here over time.
Catnip, 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 catapult, 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 catastrophe, catastrophe, catastrophe.
All right, so I'm going to go ahead and stop that video there. But basically, each progression of years of evaluation, we see further and further difficulties producing speech. And so I like to take a step back. Is there a better way we could at least describe that clinically of what we just saw, right? So this is a progressive speech disorder more so than language. And we know this because the patient's able to write language just fine. She's actually communicating more with written language than she is with speech as the disease progresses. She's got pretty much normal to very mild cognitive impairment going on. but struggles with this speech production greater than language production, and difficulties with, there's really no other difficulties with motor symptoms. So I think at least sort of thinking through, well, what are the primary symptoms here, right? So focuses us on symptoms to target first. So speech therapy here makes a lot of sense. And then thinking about ways to consider other communication, right? If the disease progresses and planning for that. But I think this is, I'll use this example in a couple different ways to think about these disorders. If we get a PET scan on this individual, this is what it would look like. So the PET scan, as a reminder, I show you guys a number of these throughout these talks, but this is measuring glucose metabolism, right? And so we can see very focal difficulties over the premotor areas of the brain, or what we call the supplemental motor areas. So right here, it's basically right in front of the motor cortex. And these supplemental or premotor areas basically help tell the motor cortex, hey, this is what we're going to do to plan some sort of motor production, right? And if this stays pretty focal, a patient may just have very mildly progressive symptoms without involving other parts of the brain. And this would be what we call primary progressive apraxia of speech. So apraxia is just difficulty with motor planning of speech. So in these individuals, they generally have an impaired capacity to plan and program speech. They may also have some nonverbal oral apraxias, which later on in the disease may disrupt swallowing. So that's another thing we have to be counseling them on and assessing every once in a while. One of the most classic ones I can remember with a patient is if I ask them to cough, which they can reflexively cough. Like, let's say they get something that, some saliva drips down or postnasal drip, and they can produce a reflexive cough. But if you ask them to cough on command, I had a patient literally just go, cough. They literally just said cough. They could not do that, nonverbal oral motor movement. And sometimes they can't click their tongue or do other aspects of this. What you'll often hear is this slow rate of speech. And this is where patients can often get misdiagnosed as a functional speech disorder. But obviously, if it's something progressive, that would be concerning. Speech initiation difficulties, and then again, this variable segmentation of words, especially repetition of more complex syllable words. You may hear about yes/no reversals, where they say yes but mean no. This primary progressive apraxia speech likely exists along a continuum of a non-fluent primary progressive aphasia. And the anatomy makes sense with these things. So premotor area being pretty focal in primary progressive apraxia here on the left, whereas more of a certainly involvement of that premotor area, but now we're starting to involve Broca's area, which is kind of a very important language production area in the brain. So sometimes the more extensive involvement of this area may produce more significant language symptoms, especially a non-fluent variant of language problems. A lot of these cases, pretty much every case that has come to autopsy, which is limited number of cases, but we're talking, Mayo has followed about 30 to 40 cases of these to autopsy, and they're almost always due to this 4R tau protein, which is in the subtype of frontotemporal diseases. Not everyone progresses at the same rates, though. Even over 5 years, only about 40% sort of evolve into a classic motor symptom or syndrome. And so this sort of distorted sound substitutions are usually younger patients. They tend to evolve into this corticobasal subtype, whereas that slow segmented speech, like our patient, they tend to be older and may evolve into a progressive supranuclear palsy subtype. So you can see similar patterns of glucose usage problems here. But this case started to have a lot of midbrain involvement and started to have a lot of, so progressive supranuclear palsy would involve some Parkinson's symptoms and falls primarily be an issue. Whereas corticobasal syndrome can start to affect motor planning and movements of the arms and legs and involve gait freezing and other motor symptoms that we might see. But obviously getting that diagnosis earlier, trying to do, be on the lookout for falls and things, right? Because it's a dramatic difference of what the next year looks like in these diseases. If somebody has a fall, breaks a hip, needs surgery, has multiple hospitalizations in a year, versus if we're very mindful of, hey, watch out for balance symptoms, I need to know as soon as possible, and get them involved with therapy early on, right? These are important differences in the trajectories of these patients. The second case, so pretty similar description of 74-year-old with 2 years difficulties getting my words out. They're leaving out connecting words and texts and messages. So sometimes it's helpful to review some of those written language examples. These texts are kind of coming in simple, fragmented sentences. They also have some other cognitive symptoms. They're not able to multitask. They're struggling with some motor symptoms of apraxia, like buttoning shirts, playing the piano. On cognitive testing, they fit more in a mild dementia range, so we're getting a little bit more cognitive impairment. They've got slow rate of speech, and I'm not going to go through some of this stuff just because I'm going to show you the video. So this one should come through too. So this is one of the things they talk about here. Just a simple, like, why are you here question, right? Just listening to her speech pattern is a important clue here.
And why are you here? What kind of difficulty have you been having?
Well, I not say the words and numbers, or write down the words, and the reading. I can't say the words, and if I the reading, but I go back to the words, and yeah.
Okay. Tell me what's happening in the picture, and try to talk in sentences. All right?
Okay. The family is going outside of the house, and the girl is putting sand in the castle, and the mother and dad is picnicking, and the wind is blowing up the flag. The radio is probably music.
And so some of the things you saw there were, there's incomplete sentences, fragmented sentences. That last one is a really good example, right? The radio is music, right? And so this really represents a different type of language problem, where it's really more of, there's agrammatism, but there's also difficulties of effortful, halting speech, right? So we call that non-fluent / agrammatic primary progressive aphasia. What does the anatomy of that look like? Well, I showed you sort of how it looks very similar to the primary progressive apraxia of speech, but it involves usually more involvement of this Broca's area and more involvement of the frontal lobe. So we tend to see a larger involvement of that frontal lobe. All right, one other case example here. So a 52-year-old comes in with cognitive concerns for the last 2 years, gradually getting worse. Speech is fluent, so different than our last patient, right? But this individual is using this and that, and just kind of vague terms to describe things while you're taking the history. They do pretty well on a cognitive assessment. So Montreal Cognitive Assessment, they score basically in a borderline normal range. But where were they missing points is always important. So some of these were on naming and then verbal memory. But like, for example, when you ask them to name these three things, right, they may say, this is a cat, this is a hippo, this is a camel, right? So they got 1 out of 3 correct there. And if you do more detailed language testing, so you do a quick little Boston naming test, they score in a very abnormal range. So they're having difficulties naming things. And then they may struggle to define words. So what is an island, right? Or what is a periscope? But their repetition of language is fine. Their speech motor production is fine. That's not really the issue here. And here is an example of someone describing that same picture you just saw, but with a different speech disorder, or a different language
There's
disorder.
a woman and a guy sitting together. Both appear to be on the verge of drinking something. There's a boy with a dog running after him who's got a flower thing, not a flower thing, I don't know what the hell you call that. That's one of those things I keep forgetting. There's a guy on over there who's evidently catching a fish. There's a boat out on the water. There's another girl having fun playing with something near the water. Yacht, guide, achi, death, knife.
Turn the page.
Skip forward to object naming.
Pen?
No,
No,
not
not
pen.
a pen.
Now hold it in your hands. Does that help?
I use them all the time.
Mm-hmm. It's called a
Scurvy? No,
There's an example of difficulties naming objects, right? So that's the primary issue here for this individual. Again, we kind of go back to that root criteria. The most prominent clinical feature here is difficulty with language. But in this specific individual, if we kind of look at our 3 different subtypes here, they're having a lot of difficulties with naming things, right? And then single word comprehension. What you may also find is a surface dyslexia. So like when they're trying to read complex words like yacht, right? They'll say yacht. They'll start to revert back to kind of, as we're learning language, some of the difficulties pronouncing those irregular words. And the anatomy of this is different. So I told you earlier, those other ones were more of this frontal lobe, right? Whereas this is almost selectively targeting the semantic language center of the brains, which usually is this left anterior temporal lobe. So it's a very different disorder. It has a different progression, much different symptoms, but a PET scan can be very good about helping diagnose that more officially, especially if that awareness is raised by a speech or language detailed evaluation. Now, I'll say one quick word on logopenic aphasia. This is one that's here in the middle. It's separate, more of in the sense from a pathology standpoint, it's due to Alzheimer's disease in over 90% of cases. Some say up to 95% of cases. In this one, they'll have difficulty naming things, but also difficulties with repeating long sentences. So I had someone describe it as like their internal tape recorder is gone, so they can't repeat the full sentence back that we may do or may give them. Sometimes they'll have a slow rate of speech because they're searching for words so often, but oftentimes it'll be a normal rate. It's just they pause to find that word. And then they'll lose their train of thought mid-sentence. And this usually evolves to also involve memory symptoms because it's due to Alzheimer's disease. And the anatomy of that looks different too. It's literally overlying the language network of the temporoparietal lobe, but certainly involving more of the posterior part of the brain, the back part of the brain, which is really where Alzheimer's disease tends to target. So, especially for these logopenic subtypes, which are a little bit more common, with Alzheimer's disease being more common, SSRIs or selective serotonin reuptake inhibitors can be quite helpful because there's often a lot of anxiety in these individuals. So if they're struggling to find a word or complete their sentence, right, the anxiety shoots up, and then it causes what I call like the worry loop, right? And that anxiety further blocks speech production, which can become a very quick vicious cycle, right? And so SSRIs can help with that stress/anxiety response. And we generally stick with something like escitalopram or sertraline in these patients. They should be given donepezil, particularly if they're having some memory issues. The donepezil is not necessarily going to help with finding that right word, but it can help with some of the other cognitive symptoms they may be having. These patients may be eligible for these new monoclonal antibody or anti-amyloid medications. This hasn't been primarily studied in these individuals, but if they meet the sort of criteria for enrollment, including not too much severity, difficulties on cognitive testing, and fitting sort of a mild cognitive impairment syndrome, very mild dementia syndrome, they may be eligible, especially if biomarkers show that it is indeed an Alzheimer's process. Speech therapy should be initiated for all PPA or primary progressive aphasia and apraxia of speech cases. There's a lot of low referral rates, which probably are somewhat due to recognition of symptoms, but it's sort of like if you have a patient with balance problems, right, you would refer them to physical therapy, and the same should go for patients with speech and language problems. So, this one study showed that 78% of patients that were diagnosed with primary progressive aphasia experienced barriers to accessing speech and language therapies, oftentimes due to lack of referral. And the potential benefits is this can help with communication strategies and aids to use in the setting of having a language disorder, but also maximizing their overall quality of life. It also allows for very much more detailed education on these diseases for patients and families, things to be looking out for, things to be mindful of. How can I best help my loved one with this speech disorder, right? And then sort of this other ways to communicate ideas too. So we're finishing just on time, but I'll stay a little extra because I threw in some extra videos which were hopefully helpful. But we discussed some of the clinical criteria for these different primary progressive aphasias, how they present differently, the frontotemporal versus Alzheimer's variant, and then discussed the role of speech and language pathologists, but also be on the lookout for motor symptoms. So I talked about how some of those speech and language disorders can progress to involve Parkinson's and balance symptoms. So being mindful of that and getting physical therapy involved early is important too. So I'll go ahead and stop there. And then I see quite a bit of action in the chat. So let me just take a look here. Most of this is code related, which is good. Get your code. Okay, pretty much all of it is code related. Any questions, and feel free to unmute yourself or type it in the chat.
Hi, this is Dr. Anshul Taneja. I have a question not specific to this talk, but about donepezil.
Yeah.
So when you start patient on donepezil, and I mean, they've been on it for 6 months and they don't see any benefit, should we continue or should we just stop it? Because sometimes I question, like when I'll see a patient back and they'll say, yeah, they've been on donepezil 6 months here, we haven't noticed any benefit. Then at that time, I question myself, should I stop the medication?
Yeah, I think in most cases, as long as there's not significant, side effects, it's impossible to have the alternative world where they weren't on the donepezil for the last 6 months, right? But I just find that oftentimes when we do stop it, then all of a sudden symptoms are worse, and it's we're dealing with a progressive neurologic disease, so So expect symptoms to get worse. If there's any amount of stability, then that's actually reassuring to me. And so oftentimes patients may not notice significant benefits, but if the diagnosis is correct, I would continue it. The reason I added that last piece is because if they've got like not Alzheimer's or not Lewy body disease, if it's more of a vascular or frontotemporal disease, then I wouldn't expect an Donepezil to help them, and in that case, it's really not indicated. But if you're pretty certain about the diagnosis, it is the correct medicine to be on, because the longer term data suggests slower progression to more severe stages too. So I would continue it. Other questions? Well, we are basically right at time, so thank you all for joining. Hopefully the videos came through well. I that's a new thing I added in, so but I think it's helpful to see different ways that the patients can present, and then obviously how those speech patterns can really differ. But all right, well, have a good weekend. Good, glad to see some videos. Yeah, so next talk will be on the 18th, and I will see you guys then.